Okay, we'll go ahead and get started. So, good afternoon, everyone. Welcome to the third and last webinar in our postpartum hemorrhage webinar series. No denial, no delay, the Alberta Interprofessional Toolkit. This is session 3 on putting it all together, perspectives on postpartum hemorrhage. This series is hosted by the Office of Lifelong Learning and Physician Learning Program. My name is Denise Campbell-Scher. I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to addressing their challenges relating to postpartum hemorrhage, which is the leading and most preventable cause of direct maternal mortality and morbidity globally and in Canada. And to start today, I really want us to take a moment and acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked this land for centuries. In terms of just a brief review of webinar housekeeping, please use the Q&A box on the bottom to enter questions for the speakers, and the chat if you have questions about technical difficulties or L3 programs and services. For the questions, please review what's been asked and upvote questions you'd like to have answered. We cannot guarantee the panelists will be able to answer all of your questions, but we will have some opportunities. So please put them in as your questions come up. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool, which is free. So for more information, please scan the QR code. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. And Main Pro Plus participants may also earn additional certified credit by completing a linking learning exercise. One of the physician learning program's goals is to improve delivery of patient care by supporting physicians and teams in data-driven quality improvement and responding to the needs of Albertans as they arise. We would like to invite anyone involved in the process of prescribing antimicrobial prophylaxis for obstetrical patients to participate in one of our ongoing projects. So if you'd like more information, please scan the QR code, and thank you so much for considering. So today we're very pleased to welcome Katie Richardson, Jaclyn Zakresky, and Dr. Philipa Brain, who'll be sharing with us the different perspectives of postpartum hemorrhage from the patient perspective and the clinical perspective, and are going to be providing guidance on how the toolkit can be implemented. I'd like to start by introducing our panelists. So Katie Richardson. Katie is a parent to 3 children and 1 fur baby. She's experienced a postpartum hemorrhage following her first delivery. She lives in Edmonton with her family and works in children's health. Jaclyn Zakresky is a nurse who's RN, has 17 years experience, originally as a pediatric and NICU nurse, and then moved to rural nursing in 2013, which is why she doesn't have her camera on, because it's a little bit of a dicey connection. It was there in the rural setting that she gained a passion for obstetrics and continued her passion in maternal and newborn care. So Jaclyn's been a clinical nurse educator for obstetrics since 2019. And over the years, she's been dedicated to educating staff on postpartum hemorrhage and promoting improved care and outcomes for postpartum hemorrhage patients in Peace River. And Jaclyn says she can talk about PPH all day. So maybe we have to clear our afternoons. And Dr. Brain is a clinical professor in the Department of Obstetrics and Gynecology at the University of Calgary Cummings School of Medicine. She's received her medical degree from Queen's University in 1988 and her fellowship in obstetrics and gynecology at McMaster University in 1993. She completed a certificate in patient safety at Oxford University in January 2023. Dr. Brain is actively involved in continuing medical education and has a strong teaching commitment through the Department of Obstetrics and Gynecology. She is the co-chair of the Provincial Perinatal Mortality Quality Assurance Committee. Her clinical and research interests involve a variety of women's health issues, including pediatric gynecology, transgender care, pregnant loss, and patient safety. So welcome, everyone. Thank you so much for contributing to this webinar, and thank you to all the participants now at 74 for your attending. And I'm going to turn it over to Dr. Brain.
Good morning / afternoon. Thank you for that introduction and inviting me to speak today. So we have a little bit of a diverse panel this afternoon, and I was asked to talk about putting it all together, perspectives on postpartum hemorrhage from a leadership perspective. I was site lead at the Foothills Hospital for 6 years when Stephanie and I got together and implemented the PPH project. And from there, I went on and did a certificate in patient safety and now co-chair the perinatal mortality committee for the province. So my lens is on implementation and follow-up of these of patients. So this is direct Alberta data from 1992 to 2019, which just reinforces the fact that hemorrhage is one of the leading causes of direct maternal death in our province, and continues to be an ongoing issue for us. As you know, the Foothills Medical Center modified the California Toolkit, which was improving healthcare response to obstetrical hemorrhage, with implementing a quantitative blood loss program at the Foothills with active management. And I think Stephanie Cooper has gone through this program with you. But what happens after implementation? So a big part of the California Toolkit also looked at using obstetrical hemorrhage measures for hospital QI projects. And so as a result of this, we have implemented an aggregate working group, which looks at a number of triggers, and I'll show you them. But one specifically is reviewing all cases where a mother received more than 3 units actually of packed red blood cells. And this was a direct effect of implementing the latter part of the California project. And this is a very busy slide, but just to show you that in March 2019, we implemented this project. And as a result, we've been able to show a reduction in the average number of patients receiving blood transfusions per month. We've also showed that the average number of packed cells transfused per patient receiving blood decreased significantly, that the total number of units transfused per month also decreased, and that the statistical analysis suggests an increased correlation between the average number of units ordered and those transfused, so actually sparing loss of unused blood products. So as a result of this project, as I mentioned, we developed an aggregate working group in the Calgary zone, and these are the terms of reference. That essentially, it started at the Foothills, and we developed a dashboard to look at this data, and then systematically are reviewing those patients who received more than 3 units of blood. The triggers for review in this committee is, as mentioned, more than 4 units of blood, but we're also looking at other triggers, including cesarean or peripartum hysterectomy, ICU admission, maternal death, maternal readmissions, and transfers to tertiary sites, and other things, including RLS and patient complaints. So what is a dashboard? We have this term thrown around. So we, as a result of being able to measure the amount of blood loss, we also can pull metrics from the charts, and I've given you on the right-hand side in the square here, you can see on an ongoing basis, we can look at our cumulative amount of blood loss, how much in 500 milliliter aliquots, as well as whether or not this was a vaginal delivery, cesarean section, or a cesarean hysterectomy. So we can do regular reviews of our progress and in a numerical value. But more importantly, this dashboard is linked to patient metrics. So this is our actual behind the scenes dashboard, and I've blocked out on the left-hand side, these would all be patient identifiers. But I can toggle through all of these things. I can ask how much blood loss. So I've picked greater than 1,500 for all delivery types. I want to look at all blood transfusions, but I've decided not to look at ICU admissions. And I'm going to look at any blood unit that's been transfused. So I get a long list of patients' identifiers attached with the quantitative blood loss it received and matched with the number of red cells. So while we've chosen to look at just more than 4 or more units of blood in our aggregate group, we can actually pull out anybody who received a transfusion, whether it was a vaginal delivery C-section, whether it was an elective section or an emergent section. So the data becomes very powerful in us being able to then review our outcomes. And when we review our outcomes, we have to do them through a safety lens, because the reason to review would be to look at, can we make improvements? Are there ways that we could have predicted that person might be at risk of a postpartum hemorrhage, for example? Were there any effects in the hospital that could have been changed to improve their outcome? And along with patient safety, we try and provide a safety rating, which is usually 1, 2, 3, or 4, based on the case that's reviewed, where 1, there was no clinical adverse event detected, and 2 would be there might have been a slight opportunity to improve things, but it didn't result in a direct effect to the patient, right down to number 4, where there was a clinical adverse event detected that would directly contributed to a poor and unexpected outcome. So through the lens of patient safety, this is how we communicate. And through these safety ratings, we can look for systems improvements. So when we review these cases of patients having more than 3 units of blood, we apply a safety rating. We look at what that system issue was and what recommendations we can make. And then we create a communication pathway. So anytime we review at the level of the committee, then it needs to go to the people on the ground through educational case rounds or quality improvement committees, and then up through to the provinces, the sites and regional committees that can affect these system improvements. And what is the hope in looking at this? This is a early warning sign or system that can be implemented in Connect Care. This particular one is a preeclampsia early recognition tool. But when we find these systems improvements, we can actually create within the system that we have already warning signs or things that might trigger you when you're ordering things, or by implementing the QBL into the system, other clinical outcomes that should occur. We can also look at other things. So we can look at the management of peripartum anemia, which I think you've already had a talk by earlier in the week, or perhaps last week. But we know that when we looked at our the people that received at least 1 unit of blood at Foothills Hospital between 2015 and 2018, that 36% of those started with a hemoglobin less than 100. So if we're going to reduce transfusion, we need to correct anemia. And we have a very robust program for treatment of peripartum anemia, which is uploaded onto the AHS website and is available for anybody. And ideally, you measure a hemoglobin and iron level at 28 weeks with the intent of improving their hemoglobin at the time of delivery. When we also know the quantitative blood loss, we can do other interesting things. This is called an allowable blood loss, which is a calculation done, and I'm showing you a app that's available to determine this maximum allowable blood loss. But basically, we can temporize this for the patient. So typical postpartum hemorrhage protocols rely on intervention at certain levels of blood loss. Phase 1 is 500, phase 2, 1,000, 1,500, etc. But if you know the patient's weight on arrival, and you know what their starting hemoglobin is, and you can calculate when you would like to know their hemoglobin approximately reaches, for example, on the left side, 80, I might only have to lose 724 cc's of blood loss to have a hemoglobin of 80, which this wouldn't actually meet our qualification for a severe PPH if you use the phase 2 cutoff of 1,000. The other alternative is if you have a patient that weighs 65 kilos that starts off with a hemoglobin of 145, and again, you're trying to get them to a hemoglobin of 80, they might be able to lose 2.5 liters of blood before you would actually need to transfuse them. So we can take the quantitative blood loss and look at our allowable blood loss and start to look at patient-centric approaches to practice. You can also take this one step further, and this is a QI project that's in the pipes, where we tend to use our cutoff at labor and delivery as being the amount of blood loss as being the quantitative blood loss. But we actually, most patients continue bleeding in the postpartum period, and indeed can bleed quite significantly on the postpartum unit, or they can trickle down to low hemoglobins. So you might have a quantitative blood loss of only 474 as listed on the left-hand side, but if you bleed out another 800 and you're not monitoring it on postpartum, then you can start to get into the phases of PPH. And this is where we see anemia happening unexpectedly. So we've developed a little bit of a pad count, which allows the patient to record approximately the amount of blood loss. And using that with the quantitative blood loss on labor and delivery can give a meaningful predictor of potential anemia on postpartum. Anemia has been associated with poor bonding, difficulty breastfeeding, anxiety, and depression in the postpartum period. So the quantitative blood loss becomes really important in being able to predict other more long-term postpartum concerns. The other thing you can do, which is on the reverse side of this, is actually reduce the number of blood tests organized when you know you have a low blood loss. So we know, because we do quantitative blood loss at elective cesarean section, our average blood loss is around 500 cc's. And this is a provincial initiative which I'm championing for the province, which is reducing the number of type-in screens at elective cesarean sections, recognizing that a type-in screen costs about $62 to run, 30 to 60 minutes of a lab text time, and 5 test tubes to complete. And we should be able to target a type-in screen to about 20% of our sections, and some places in the province are sitting at about 80%, with an overall savings to the system over a few years of about $500,000. So we can also use quantitative blood loss to guide our elective processes, not necessarily for postpartum hemorrhage, but also to improve systems on the reducing of blood typing and screen. The triggers that we use for doing a type-in screen are pretty obvious. Abnormal placentation, preeclampsia, general anesthetic, again, a low hemoglobin, which theoretically should be correctable, multiple cesarean sections, and clinical significant antibodies. So I'm going to stop there. I'm hoping that you can see the benefit both from a safety perspective of being able to quantify blood loss, link it to patient metrics, and put those difficult cases through the lens of a patient safety review with potential recommendations and systems improvement, but also to guide care and expand on our potential for improving care both in the postpartum world and also to potentially save money for the system by reducing unnecessary testing.
Dr. Brain, I don't know if you'd like to answer one of these questions sort of in the chat or take some airspace for it before I get started.
So let me just look at this. So when at what hemoglobin would you recommend for iron infusion on postpartum versus an RBC infusion? Yeah, that's a really good question. So when we looked at that technically, there is a whole postpartum, again, anemia protocol. You can typically less than 100 has been the sort of goal for potential infusion, and there isn't a one-time infusion that you can use. We have also typically used a cutoff for transfusion at 70, but if the patient is actually quite stable, you might choose to do an iron infusion at lower hemoglobins and spare the patient the risk of a blood transfusion and the cost to the system. What is the name? It's MD Calc is the app, and it's free. And there is quite a gazillion different calculations you can get on it. But the allowable blood loss, that's MD Calc. Oh, and the same question again about the ABL app called. You can just download it on your app, on your phone.
And fantastic. And there was also some really great points on at different points in pregnancy, I think, in the previous webinar around trying to get people built up in a timely way before they actually get to delivery. So if people haven't had a chance to see that wonderful webinar, I recommend that have a look at that. Okay, Katie, you're up. Thank you so much, Dr. Brain.
Yeah, thanks, Denise and Dr. Brain. So as Denise said at the front end, I am Katie. Good afternoon, everyone. I live here in Edmonton, and I'm a social worker in children's health. I'm here today to share my story of postpartum hemorrhage with you. I am going to share my screen if I am able, just so you can see some photos. Can you see the photo of my family? Dr. Brain, maybe you could nod at me. You see? Yeah, okay, awesome. Oh, no, we lost it again, didn't we? There we go. Yeah, and it should take me sort of about 10 minutes to talk my way through this. There we go. So here I am with my family. This photo was taken in 2018. At this stage, I am already 5 days overdue with my first baby. These are my stepkids, Charlie and Aaron. And as the owner of a large dog, I feel compelled to tell you that that is not my doodle. That doodle belongs to my mom. So my pregnancy, I was 32 at the time and, kind of managing a chronic iron deficiency, but otherwise healthy. I was followed by family medicine and had a fairly uneventful pregnancy. I did have a subchorionic hematoma that burst around 14 weeks. That was a bit of a surprise, but otherwise, like I say, very, very uneventful. And so as you heard, I went post dates. In this picture here, I am 11 days overdue and heading into the Grey Nuns in Edmonton for induction. We're excited, as you can see. I feel like I was on the drip for ages. There were, it seems, 1,000 shift changes in the time that we were trying to get things moving. My own family medicine provider saw me repeatedly and then also brought in the on-service OB to continue to up the ante. My membranes were ruptured in the early evening and I labored overnight. This is my sister. She is also a family doctor. From what I understand, I have nothing to compare it to, so this is sort of the flaw in my story, but from what I understand, I had a truly excellent epidural. By morning, I was ready to push, which I did for about 2 hours, and then ultimately, due to Babe's posterior presentation, we moved to a section. And so this is the first impactful moment that I really want to underscore for the audience here today, and that was around the OB's informed consent process. So at this stage, I have been awake for well over 24 hours. I've had more interventions than I've ever had before in my life. I am pretty exhausted from pushing, and Dr. Jean Mohammed's real grounded presence and his clear explanation of options and risks and benefits was tremendously valuable to me. Nothing about this delivery was going as I had hoped, and so the way that he engaged me as an unfocused, cognitively impaired in that moment patient was really, truly a work of art. So after I consented, we moved fairly quickly into the OR. Here you can see that anesthesia took some photos for us, and Elliot arrived, perfectly healthy. She was 9 pounds, 2 ounces. We had our golden hour in recovery. And she nursed. This is one of my favorite photos. It's of her cranky little eyeball. And so it was while I was transferring to recovery that I had what I would describe as a sensation of gushing. I said to this 2 staff, nursing staff, at least one of them, I think, who were taking me to be roomed, like, hey, I'm sort of have a bit of a sensation of gushing. Is that what I'm supposed to be feeling? And this is really impactful moment number 2 that I want to underscore, which is the communication around the actual hemorrhage in that moment. The nurse looked me dead in the eye and she said, things are about to get busy, but you are okay. And then she called the code, and then the hullabaloo. And then the other thing I really remember really clearly about that moment, again, is Dr. Jean Mohammed's communication. He was really validating the pain that he was causing me. I'm not a physician. I don't understand sort of what the protocol is here, but I recall that he was really massaging my abdomen and that hurt like hell. My anesthetic was wearing off and, he's pulling on my incision. And, in that moment, I really recall him like really connecting with me and sort of saying, I know this is painful. This is why we're doing this. And so I had a sense of, having pain with a purpose. So here's my mom, Grammy. You can see that I look unwell. Before the hemorrhage, my family had been cued that I was roomed. And so they were on their way as the code was called, I think, and then told to wait. This caused my mom a proper panic, as I'm sure you can imagine. And her fear has had a really lasting impact on me and how I remember what happened. And it does make me wonder about, if there was any opportunity to improve the communication with my family, how my family was managed during that moment. In the end, I had a 2-day admit to postpartum. I recall waiting for labs to come back before I could go home. I remember really clearly the discharge instructions around what to watch for, clot size, risk of infection, things like that. I definitely remember that we did repeat labs at 6 weeks, my follow-up with Dr. Wismark to make sure that my iron count was rebounding. And so, you know, for me, I've really started to conceptualize the postpartum hemorrhage in retrospect as a sort of small t trauma, partly because of the lasting visual reminder of the blood loss. Like all of the photos, as you can see here from Ellie's newborn period, feature me looking really ghostly white. And also because it took me a while to really wrap my mind around, fully understand what happened and what the risk was. And so this is really, you know, kind of my takeaway message for the audience, my takeaway message for you. In the months that followed, I had to reckon with this part of my birth story. I had to wrap my mind around what happened as the dust settled and I settled into parenthood, and the intentional, powerful communication from the healthcare team at those two key moments was probably the single most protective factor for me in going back and remembering and seeking to understand. You know, I had those two moments as touchstones in what happened to me. So I did not have a team initiated, like, or healthcare provider supported sort of debrief or opportunity to consolidate my experience. You know, as someone who works in pediatrics, I'll say that I'm not sure that that psycho-emotional service is yours to provide. I think there's a limit to what healthcare providers and hospital systems can take on. But I do hear a lot of talk about birth trauma in the personal and professional circles that I travel in. And so I wanted to underscore the opportunity to mitigate the risk of trauma, that, you know, this was really valuable for me in the aftermath, that the healthcare providers in the moment took the time to really explain to me what was happening. The other wonder I have, you know, for consideration is whether or not there are implications for prenatal care. I haven't participated at all in the webinar series. I don't know much about the toolkit, so maybe this is already on the radar. But yeah, I wonder if there is an opportunity for education for patients prenatally. I'm sure that's not appropriate for all pregnant people. But for me, I did a ton of learning and reading in preparation for delivery, for parenthood. And so, you know, for example, I knew about the increased risk of going to section and having other interventions when I went in for induction. And that really helped me to be flexible and accepting of how my delivery unfolded. But I didn't have postpartum hemorrhage on my radar at all. Yeah, and as somebody who struggles with iron deficiency, it's something that I maybe could have benefited from knowing a little bit more about. And so, yeah, happy to take questions now or at the end. This is Elliot and I this past summer in Calgary. We're paddling the bow there. She is healthy. I am healthy. We are doing well. It's a good news story. And yeah, really grateful for the opportunity to share my experience with you today.
Wow. Oh my goodness, Katie, thank you so much for sharing your story. So incredibly powerful. There are a couple questions popping up. So folks, pop your questions in the Q&A. People saying thank you. Megan saying thank you for sharing, Katie. Rachel's sharing that she experienced something similar in a rural site with 4 units of blood. Having been a rural family doc, I know that in our town, we only actually had 4 units of blood. So, wow. Sounds like her story was similar, and glad she had a good outcome. Yeah, they had a good outcome. So does anybody else on the call have any questions for Katie? I mean, you can also pop them in the Q&A as Jaclyn proceeds. Yeah.
I'll monitor the chat there just in case, Denise. Thanks again, everyone, for the opportunity. I haven't actually really talked about it since it happened. So it was sort of fun to think it through and go back through our photos.
Yeah, wow, fantastic. Well, thanks so much, Katie. Okay, Jaclyn, we'll turn it over to you now. Jaclyn's got some connectivity challenge with the video, so you won't get to see her, but you'll hear her.
That is correct. Thank you so much for having me, and thanks for speaking so kindly, Katie, about that experience. That's what I work on up in Peace River. So as it was mentioned before, I am a clinical nurse educator for the past 4.5 years. And 1.5 years ago, I took on PPH as my personal pet project, and to improve and to work on implementation and team engagement at our little rural site in the middle of what feels like nowhere. So I was asked to talk about how I got my team engaged, how I've maintained that engagement across the last year and a half since I kind of began the project, or almost coming up on 2 years now, and to talk a little bit about how that affects our patients. So I'll get rolling in that. So it started off that the team kind of engaged themselves, which was really nice. The staff identified that there was a need for education because they were feeling uncomfortable with managing patients experiencing PPH. This was largely due to, luckily, low volume, but it's a low volume, high risk activity. So we started with collecting a team, our Moro B team in Peace River, and we collected some doctors and nurses on the initial team who could spread the news about practice changes and exciting learning opportunities to improve. So once everyone started the education process, staff were excited to try out their new learning and skills. And then with regular simulation, we were able to keep staff engaged in the principles of PPH. As I kind of mentioned before, this is a high risk, low volume activity up here for us because we are a level 1 site. We do low risk deliveries. So we wanted to maintain those skills and keep people thinking about PPH even in those times when they hadn't happened for months at a time. So we set up and organized some regular PPH simulations and education review, and kept forward that systematic approach to postpartum hemorrhage to keep everyone interested. And this goes back to that toolkit that we have all learned about in previous days as well, and making those adjustments, making sure that we have them accessible to our staff members on a regular basis, and to just keep the buzz going, keep talking about it. To this day, I still have people asking for when we're going to run the next round of education as we move forward in our process. And we have noticed some positive changes in outcomes as we rolled through the project. So our staff comfort improved. And what I found was really amazing when our staff comfort improved is that the communication actually improved, not just between staff, but also with patients. Much like with Katie's story where she was talking about those pivotal moments where you are talking to your patient and telling them this is what's going on, it's going to get busy, all of those things. We've managed to improve that in Peace River as well. So having those talks with our patients, and even sometimes we're doing debriefs afterwards, or that's kind of our next phase level, is to debrief with them and say, do you have questions? Do you have any, do you need some answers as to what happened with you? And sharing that time with our patients. We also noticed that with the standardization of roles on the interdisciplinary team, that we were improving that care as well. And we're noticing earlier recognition and intervention of PPH in the care of our patients. We're not wiggling around. We're using that quantitative blood loss. And when we're using our QBLs, we're responding faster, which is super crucial in our site because we only have 4 units of O negative blood to give as well, as was kind of mentioned to our rural physician. So if you're wondering about implementation, how you're going to put this all together for your site, we all know the old saying that Rome was not built in a day, and neither was this PPH project. So I liked to think of it kind of like a puzzle. So we built the edges first, and then we worked at different sections. And at the very end, we had a complete picture. So this, like I mentioned before, started with assembling a robust team, nurses and physicians. And then we moved into creating the cart and essential materials and documents, or collected them. And then we created education, including a PowerPoint, your skills stations. And once it was all together, the project kind of really got underway and we got to see the whole picture. And last but certainly not least, here are the lessons that I have learned. And I must also give credit to the Foothills Project, the No Denial, No Delay that they began. I piggybacked off a lot of their amazing work and just tailored and tweaked it a little bit to our small site. So what I had learned is that to take on this project, it was easier to do in small sections. Working on this little by little made it completely manageable. So we started with creating that cart and then moved on to the education and training, and then that continuing education as well. The other thing I learned is that the best attended groups were the interdisciplinary education and simulation. So having that approach really helped with the perspective and guidance, so all healthcare professionals could get a feel for all of the different roles and responsibilities related to postpartum hemorrhage. And of course, plan to train as many of your staff members as humanly possible. And hopefully you'll be able to get all of your team members trained over a few months. We offered multiple sessions during different times of day to accommodate all schedules, and we even ran simulation with various members of the interdisciplinary team, not just nurses and doctors. We got lab involved in some of our simulations. We also got pharmacy involved in some of our simulations. It was truly a multidisciplinary approach, which was very lovely. And I know that's quick, but I talk fast. Any questions in the chat box or anywhere else for me?
Awesome. Oh my goodness. I feel like, Jaclyn, you just sort of pulled everything together, which I know is effective. That's so powerful. So folks, just while you're reflecting on Jaclyn's synthesis, there is a question. Please put your questions in the box. Virginia has a question for you, Dr. Brain, where she's saying that I work in a rural site where we do not have the lab after 4 p.m. We do CBC and type and screen on all women, so we have this when they're in labor. Should we revisit doing the type and screen now that we have 100 deliveries a year?
Hi, Jenny. Nice to see your name in print there. Just to be clear, the reducing type and screen is for elective cesarean sections at this point. And so I think ordering a type and screen has to be tailored for the availability of your site specifically. So I'm assuming that some of those patients are going to be failed vaginal deliveries and end up in C-sections. You probably can tailor a little bit to risk going into it, but yeah, it has to be tailored based on availability at that site. But also, I would assume with doing 100 deliveries a year, you also are pretty twitchy about your risk prior to going into a delivery ahead of time as well. I hope that answered your question.
Perfect. So Jenny, if you have more follow-ons, please just pop them in the Q&A. Leslie's asking a question about Jaclyn's contact information, which I'm assuming is maybe related to wanting to do something similar, Leslie, at your site. So I think you could probably contact Jaclyn through, is it Peace River, Jaclyn?
Yep. And I am first name, last name at ahs.ca. If you want to contact me through that, that works just fine.
Awesome. Thanks, Jaclyn.
No
Actually,
problem.
I have a follow on, and Jenny's got a note in here. Thanks. We've had some disasters, so good to know. Great to see you as well. I have a question just while we're waiting for the for folks to pop in the chat. Jaclyn, it just seems like such an amazing implementation process, and probably yourself and Dr. Brain could comment on this. There's a lot of moving parts, and you're in really different contexts with being in a big tertiary center and in a smaller center. What did you find as being sort of the magic pearls on how you were able in the different contexts to pull this off? It's really amazing. So, and were they similar things in Peace River and in the big city, or were they different?
It was interesting to say the least. How we managed to pull it off was due to a great part of a wonderful group of people who came to see us in Peace River and this provincial working group that's related to Mincy as well. And so I joined this working group before I even began my PPH project, and then just jumped on the side. And then we had the opportunity to bring some tertiary level people. Dr. Stephanie Cooper came, Megan McQuiston, Megan Gleddy came to Peace River to see what it's like, because we were creating a lot of materials out there with that stage 1, stage 2, stage 3 PPH. And once those were created, we tried them in rural sites and it just didn't fly. So we were revising and revisiting, having that kind of stage-based interprofessional disciplinary checklist so that every PPH would be treated the same, regardless of whether it's going to be at a level 3 site or a level 1 site. Now, that being said, I do recognize that there are more hands in a level 3 site and more specialties. And so I don't want to say it's easier. It's definitely not. PPH is not easy, regardless of what level of hospital you're at. But it just made it very distinct. So you just, if you don't have interventional radiology, for instance, at your site, we just didn't do that. We just moved to the next part of that checklist and just continued through. And the more I kind of taught it, and the more we looked at those tools that are now in that wonderful toolkit that we're all learning about, it made it just really solidify in my brain that this can be done, and you just have to, there's great tools out there, you just got to use them.
Mm-hmm. So would you say, did you have a working group at your site where people came together and were sort of working on this on a consistent schedule where it was planned?
Yeah, so we had we met every month with our MOROB team, and they actually helped more with the creation of the cart. So what do you think you would want on the cart? You know, your Bacary balloon to your saline bags to what medications. And so we were moved more on that. But that was the time where I joined the provincial working group to come up with those other documents, the medication table, the interprofessional stage-based checklist, and to really put that other stuff together. And like I mentioned earlier, piggyback off the work that had really started at the Foothills, which was amazing work. And I can't say enough good things about, for sure.
Yeah, awesome. Well, that's a good segue actually to ask about the Foothills. Philippa, could you comment on that? Because I mean, it's such a different environment. Like as Jack, you were talking about, specific roles for different people on the team. I remember my first code when I was rural, it was an adult heart code, but I was like, where is everybody? Because in the big city, there's like a cast of thousands. When you're rural, there's nobody, right? So how did you guys handle getting all the people at Foothills on the same page? And what were the ways that you did that?
Yeah, it's a really good question. I mean, hats off to Stephanie Cooper and Anita Zakresky. Anita Zakresky is our CNE at the Foothills, who really championed this cause, but we also engaged a RN who also is in QI, Pam Nugent, and she was really key in sort of planning the process. Anita and Stephanie and Pam developed these things called the Red Room, where there were games and prizes, and we really had to sort of socialize it with the team on the ground. But with Pam's help, her and I sort of on the administrative side got a grant to get some money to get these carts available. So we have a couple of PPH carts which are quite fancy on the unit, as well as to provide educational tools. Anesthesia was more used to the idea of QBL because of their trauma care that they do here at the Foothills. So I think they were an easier sell. The obstetricians were probably the hardest group, in part because PPH is such a part of our world that we all think we handle it well, and did we really need to do all of this extra? But I will say it's really interesting. It's become part of the scenery now. So we have QBL at all of our deliveries, including elective cesarean section. And it's just routine now that you'll get the running upgrade. Your QBL is 300. Your QBL is 450. It's just become part of the woodwork. And I think it has made a significant difference. The cost was a potential issue. Stephanie and Anita had to suss out cones that would measure the blood volume at a vaginal delivery. So there was quite a bit of workarounds and implementation that had to occur. And I think part of the buy-in and trying to get other sites to do it is to rationalize the cost of some of the additive things you need to do in order to be able to do it. The weigh scales, for example, so that you can weigh blue pads. They're needed for the sponges in the OR. But ultimately, once it's like anything, once sort of change practice, once it's embedded, it's just become so part of the woodwork now. And I think a real opportunity to take those numbers and advance it to some of the other things I showed you about. But honestly, I mean, it was Stephanie and Anita who really championed the cause. And through MOROB, we have a pretty robust MOROB committee here at the Foot too.
Yeah, wow. So there's so much to unpack there. Can you tell us about this Red Room? Like, what was that about? And what kind of role did that have in terms of getting folks kind of on board?
Yeah, well, I think we all struggle with communication, and especially the vast number of nurses that work at the Foothills between the casual and the permanent lines, and how, you can put posters up on the wall, but you have to get people to read them. So they had put together some kind of a labor and delivery room that they called the Red Room, and there was sort of information booths there, little games, things that you could do, to little prizes that were available, coffee cards and things to really engage the nurses so that they would come and read the information. And it did take a good, I would say, 6 months to a year for sure to kind of get it within the sort of nuts and bolts of the establishment. But now it made me smile the other day because it's just so part of the woodwork now. And it's been really interesting to be able to take it to these other places of kind of looking for systems improvements and things, which is the part that you don't think about. Sure, we need to improve clinical management. That's got to be our forefront. But you can improve clinical management by doing other systems improvements around it. So, and I think reassurance that the, people worried about not being able to get stat type in screens, that we had to show that we're actually making a difference. So Pam Nugent was really important in producing those graphs that showed actually we are changing things, we are making it better. So there's a little bit of that sort of feeling of accomplishment, which I think is important in sort of keeping the project going.
So incredibly cool. Okay, I'm asking way too many questions, participants. So please stick stuff in the Q&A because I'm going to just keep going here because I think it's so interesting. So you allude to both of you that you were able to get the whole team on board, get people cognitively engaged with figuring out how to integrate this work into their daily flow. How do you sustain it? So there's so many different things that have been going on. There's different things that come down the pipe. Philipa, you mentioned that now people just get this update as a regular matter of course. What would you say are the current things that have to happen to keep it happening? And what do you think made a difference with that? Is it the fact that you had those data to show people, hey, the stuff you're doing is making a difference? Is that the piece, or what was the piece?
Well, I think also changing policies. So it's now a policy that you put the QBL in, and we had to work with data. And again, of course, we were on SCN when we implement SEM when we implemented this project, and now we flipped over to Connect Care. But we had to work with the data analysts. Where do the nurses put the number so that we can actually extract it to be able to use that as information? But it's become one of those things like a vital sign. It's just an expectation that the QBL will be written down. And so I think having policies, physicians are not terribly rule bound, we're terrible, but the nursing staff are. And so creating these sort of policies as well as auditing, I have in my dashboard the number of QBLs that aren't present. So we did do some auditing along with that. Yeah, and I think Connect Care being across the province, that can be more easily standardized than individual practices amongst hospitals. So I think being able to make this adaptable at other sites, recognizing the level of care, is also going to be perhaps a little bit easier with the implementation of Connect Care.
So interesting. I know in one of the other webinars, one of the speakers was teaching about how just the clinical observation can be a little bit, you can get behind the 8 ball in terms of what's happening with the blood loss. So this seems like such a powerful innovation. And so it'd be great to see how, I think that sharing that wisdom of how you got that into process, not just as a number, is so important, hey? And Faye has a question here about whether or not there's plans to edit the Provincial Connect Care Delivery Summary to include QBL. And it says, currently I understand the nurses have to do workarounds to include this information. And Faye is working in Family Med at RGH in Calgary.
So I can speak to that. I work a lot in Connect Care. It's my other home. So part of the delivery summary, there's actually a button in it that says QBL. And they've removed in the delivery summary anything that says estimated blood loss. So they have actually made it more difficult for us to use estimated blood loss, our thing of the past. And it really has forced our nursing staff to use that quantitative blood loss either through the flow sheet or through that delivery summary. And so that's what it should show up. And it is, yeah, I see that. Holly, you're agreeing with me. It is easier to do that QBL now. And I got to tell you, I actually love the QBL calculator on Connect Care. It is super slick. All you have to do is, hey, how many linens of what type and how much one of them weighs, put in your total volume that you weigh at the bottom, and it calculates for me. Like, I don't even have to math it out anymore. I love it so much. Anyway.
That
as you can
sounds like
tell.
such a practical tool when things are unfolding so rapidly, potentially, right?
Absolutely.
Yeah. How does that play out in your setting, Jaclyn? Like, I can imagine that there would be times where you wouldn't have as many team members, maybe just available for handling this. What are the workarounds you guys have had to do in sort of operationalizing that and making it part of routine care?
So using it as part of routine care for our average deliveries who are not necessarily hemorrhaging, maybe who have lost a bunch of blood, but now they're stable, we'll just set the linens aside and weigh later. And we act more on the active amount of blood loss as opposed to finding out those numbers in real time if we don't have enough hands. Another like tidbit or tip or trick that we use here is when we're at that point where we're needing to get blood, packed red blood cells, or anything else from the lab, our lab or our unit clerks have now been trained and done a specialized course that they can actually pick up the lab from the blood from the lab for us so that we're not using a nursing runner to go and get things. And they also will grab our bear huggers, warm blankets for us, anything that we need on the ward because they're familiar with the process as well. So that's another little helpful hint, but it can be quite challenging with not too many hands, and we tend to probably do things faster. For instance, we would probably put in an IV, a second IV, faster maybe than a center that could get one in lickety split. Yeah.
Wow, so practical. So this just sounds amazing, and kudos to the whole working group and team and Stephanie and everybody. What's the next steps, Philippa? Like, what are the next things this team is working on? What's happening with scaling and spreading this?
Yeah, yeah, that's probably a question that Dr. Cooper could answer better because I know she's trying to do a provincial initiative and I'm just not clear whether that's through Mincy or how that's happening. I think from our perspective, I like the idea of sort of tailoring it rather than just reacting necessarily to the amounts of blood volume per se, and not to be caught out by someone who comes in with a hemoglobin of 95 who might be at transfusion level with a blood loss of 600 and we wouldn't think about it because we haven't reached our 1,000. But the flip side to that is that you might have somebody who has a hemoglobin in the high 140s who probably could lose 3 liters before they're at a transfusion range. So it doesn't mean you don't do a type and screen. It just allows for thoughtful use. I also think we should be predicting anemia for postpartum specifically and how we should tailor our postpartum visits specifically to risk factors that happen in the hospital, one of which should be anemia, hypertension, other things. So one of the reasons to look at readmits in our aggregate group is to look at those people who are readmitted either with a delayed PPH or requiring a transfusion or hypertension that becomes critical. Could we have done something to monitor them that would have prevented them having to be readmitted? So how do we tailor postpartum care?
Okay, so interesting. Ashley has a question in the chat, or in the Q&A rather, about whether you use bear huggers for all PPH in labor rooms. Is this part of the PPH algorithm?
So we don't necessarily always use bear huggers for PPH in the labor rooms. You certainly can. We have one that's a little ways down the hall, so sometimes at our site, we don't think about it as fast, but we do have the blanket warmers. So keeping our patients warm with blankets and keeping the patient warm is part of that interprofessional stage-based checklist as well. So it is on there so that when you're going through step by step to make sure you didn't miss anything, like putting in a Foley or anything else, it's on there as warm, keep your patient warm. So you can choose your own adventure as to how to do that, whether that be through warm blankets or through a bear hugger.
Great. I want us to go back to Katie. On that, Katie was talking about, perhaps an opportunity to support family. It sounds like sort of the stress that was on her mom was quite significant. Is part of this process now that you've got everyone feeling more comfortable, and Jaclyn, you alluded to, communication being definitely enhanced with all this work. Is that on the radar about how to support the other folks around, or how do you guys handle that, especially if you don't have a lot of warm bodies?
I would like to say we're a work in progress in this department for sure. If we do have enough people, enough hands, we will try and designate someone to talking through stages with the mom. And in part of my education, together, we talk about that, about how this is an emergency, how this is challenging. This is a lot on the patient and their whatever other family members are with them. So it's really important that we continue that conversation with them, even if it's just so as quick as to say, like Katie mentioned, like, it's going to get busy up in here. Or maybe you don't have time to give them a lot of details, but just look them straight in the eyes and say, I'm going to do this, and then I'm going to come back and see you again. Like, I'm going to talk to you again. I just need to get XYZ done. I'm trying to help you. So I'm hoping that our staff, again, are working through that process. And as they're feeling more comfortable with these PPHs that come up, we're having those better communications. And then that final debrief at the end, once our patient is stable again, is super important. And what I mean by debrief isn't the inter-staff, but the debriefing with the patient.
Yeah. And just a last thing on that, to Katie's point, what she had brought up was perhaps some education prior to going into labor and delivery around the fact that PPH can happen. And I'm not sure, is that something that is often discussed with patients? Or Dr. Brain, what do you think about that? Is that something that could be helpful, or is that what's your thoughts on Katie's comment on that?
Yeah, it's challenging because you're always faced with the how much information is too much information, and what point do you start to scare your patient versus not scare your patient. And I think there's definitely people that we would talk more consistently about it. People with placenta previa, for example, or abnormal placentation, or low platelets, for example, with preeclampsia. But I think if we were to go down this sort of risk factors of PPH with every patient, I think that we might have some people quite concerned. I don't know how we find that balance, but I was reassured that for Katie anyways, that you had good dialogue with your obstetrician, because I think that's really important in the moment of some of these traumatic experiences. And I don't think we're as good about the debrief after that we could be as well, but those are things to work on.
Yeah. Katie, did you have any last pearls you wanted to share, or we really should give you the floor?
Yeah, I would just say, I said it already. It dawned on me so slowly. Like, it's like, I don't know if that's like postpartum amnesia or like how that kind of works for me, but it took me a long time to really understand, oh yeah, like I hemorrhaged. And so because that communication had been so powerful, I was able to go back to it. Like as I kind of consolidated what it meant to me, I was able to really go back to, those moments that I shared with you today. And so I think, even in the absence of a debrief, healthcare providers have a really powerful opportunity to communicate clearly in those moments, and that's protective in the long run.
And we have a little bit of wisdom also in the Q&A from Jenny Limoges and Tiffany Woodland from the angle of midwifery. And so Jenny was sharing that we tend to review complications from birth and postpartum as part of our 36-week visit at our practice as midwives, and our clients report finding it helpful when emergencies like PPH occur. Tiffany is sharing, considering midwifery is rooted in low intervention philosophy, it's not our typical practice to insert an IV saline lock as a standard for client at low risk for PPH, but she's commenting that considering the rates of PPH have been on the rise, it's making her wonder whether that may be something to review. And she asked if there's might be any updated recommendations within our zone regarding IVs reconsidering the rising rates of PPH. I don't know if anyone can comment on that. And Erin's echoing that the PPH is a primary topic at the 36-week visit as well. So that's really helpful. Thanks so much, Erin. Did you guys have a comment for Tiffany on IVs? Is that something everyone should be considering using?
Well, I think one of the things that's interesting about being able to measure QBL is our lowest rates of blood loss are at spontaneous vaginal deliveries and elective sections. And once you start getting into things like forceps or a failed vaginal birth and have a C-section, then your rates go up. Also, you'd naturally get an IV with an epidural. And at our site, we have a relatively high epidural rate because we have access to 24-hour anesthesia. We did find when we implemented this project that our PPH rates went up. Of course, we chronically underestimate blood loss when we just visualize it on the floor. And so we actually did find our type and screen rate, which originally had been quite low, go up with the PPH project. And this is where I think it's important to try and now kind of temporize it with the patient a little bit. You're always going to have to deal with acute blood loss with kind of replacement, obviously, but I think we have to walk that fine balance in obstetrics between over-intervention and sort of being proactive, and certainly being proactive has shown an improvement in this case. So if you know how much blood loss you've got, you can react to it as opposed to being caught unawares. And I would also say that with the checklists, that allows you to remember, oh, these are the things that we need to do, including implementing consultation if you're a low risk of midwife at sort of reasonable levels of blood loss to get obstetrics involved, rather than waiting until they're hypotensive, which can happen if you're not regularly measuring. So I don't know that starting an IV necessarily is the answer to everybody, but just being more aware and proactive.
Okay, well, that seems like a wonderful note to end on. So interesting. And I know Katie just put in the chat she had to pop off, but just want to say thank you so much to her and Jaclyn and Philipa, to you guys, for all of your wisdom, expertise for this amazing project. Just such a really amazing project. I'm so excited for the for the advancements in this. And really, it looks as though there was a comment in the Q&A that it looks like there's some plans afoot for provincial spread, and I think that's just so wonderful for everybody in Alberta. So thanks for all the hard work. Thanks for sharing it with the webinar, and thanks so much for the great pulling it together. And thanks to everybody who's attended. So much appreciate you guys coming out. And yeah, this has been great. So happy holidays, everybody. Have a good clinic this afternoon, or whatever you're up to this afternoon, or whatever. And thanks.
Thank you.
Thanks so much, everyone.